Foundations of Maternal Newborn and Women's Health Nursing by Murray, McKinney, Holub, and Jones. 7th edition. Chapter 21. Care of the Normal Newborn. The role of the nurse in ongoing assessments and care of the newborn in the birth facility is to help the newborn and parents have a successful transition after birth. The nurse identifies and responds to changes in the condition of newborns as they adapt to life outside the uterus, keeps infants safe, and teaches parents how to provide care. Nurses often receive questions from parents about care of infants after discharge. Infant home care for the first 12 weeks of life is discussed. Detailed information about ill or older infants can be found in pediatrics textbooks. Inpatient care. Early care. Early care after birth involves assignment of APGAR scores and assessment and stabilization of the infant as necessary. Once the infant's condition is stable and he or she has had the opportunity to bond with the parents, prophylactic medications are given. Ongoing assessments continue during this time, including temperature, heart rate, respiratory rate, and character, skin color, muscle tone, level of consciousness, and activity level. These assessments should be documented every 30 minutes until the newborn is stable for 2 hours. Because of blood and amniotic fluid on the infant's skin from birth, the nurse wears gloves during all contact with the infant until the bath is completed. After the bath, gloves are necessary only when contact with body fluids may occur. Administering vitamin K. Vitamin K is given to neonates because they cannot synthesize it in the intestines without bacterial flora. This places them at risk for hemorrhagic disease of the newborn. 1 dose of vitamin K intramuscularly after birth prevents bleeding problems until the infant is able to produce vitamin K in sufficient amounts. Although the injection is usually given within the first hour after birth, it can be delayed until the infant has finished breastfeeding at birth. Providing eye treatment. Infants also receive prophylactic treatment to prevent ophthalmia neonatorum, conjunctivitis that is most often caused by Neisseria gonorrhoeae, acquired from the mother's birth canal. Because this infection can cause blindness if not treated promptly, most states mandate prophylactic treatment within 1 to 2 hours of birth, regardless of mode of birth. Erythromycin 0.5% is most commonly used. Tetracycline 1% ophthalmic ointment also may be used. Topical antibiotics are not effective against chlamydia, which often occurs with gonorrhea. Because the ointment may temporarily blur the infant's vision, parents may wish to delay treatment for a short time during initial bonding. It may be delayed until the end of the first hour after birth or after the first breastfeeding. Some infants develop a mild inflammation a few hours after prophylactic treatment. Any discharge from the eyes, especially if purulent, should alert the nurse to the possibility of infection. A culture may be ordered, and the drainage should be removed with sterile saline and a cotton ball. If the mother is infected, the infant needs additional antibiotics because routine prophylactic treatment may not completely prevent infection. Application of the nursing process. Cardiorespiratory status. The transition from fetal life to neonatal life may include temporary problems in cardiorespiratory status. Assessment. Assess the newborn for signs of difficult transition. Note the rate and character of the heart rate, pulses, respirations, and breath sounds. Look for signs of respiratory distress, including tachypnea, retractions, flaring of the nares, pallor or cyanosis, grunting, seesaw respirations, and asymmetry of chest movements. Check blood pressure if indicated. Identification of patient problems. Fluid from the lungs must be removed by absorption or drainage from the respiratory passages after birth. This does not happen immediately and may cause a temporary problem during the early hours after birth. A common patient problem is difficulty clearing the airway because of excessive secretions. Planning. Expected outcomes. The expected outcomes for this patient problem are that the newborn will do the following. 1. Maintain a patent airway as evidenced by a respiratory rate within the normal range of 30 to 60 breaths per minute. 2. Show no signs of respiratory distress, retractions, grunting, nasal flaring. Interventions. Positioning and suctioning secretions. Position the infant on the back with the head in a neutral position or to the side. Use the bulb syringe, if necessary, to suction secretions as they drain into the infant's mouth or nose. Suction the mouth first because the infant may gasp when the nose is suctioned, causing aspiration of mucus or fluid in the mouth. Then suction the nose gently and only if necessary. Suctioning is traumatic to the delicate tissues and may cause edema of the nasal passages. Keep the bulb syringe in the crib near the infant's head, where it is available if needed quickly. Teach both parents how to use the bulb syringe correctly. Send the syringe home with the infant so the parents can use it if the infant experiences a problem. If mechanical suctioning is necessary to remove deeper secretions, choose a small catheter to avoid damaging the tissues of the respiratory tract. Suction for no more than 5 seconds at a time, using minimal negative pressure to avoid trauma, laryngospasm, and bradycardia. Apply suction only as the catheter is being withdrawn. Providing continuing care. Continue monitoring the infant for problems throughout the stay in the birth facility. By the second period of reactivity, the infant may be alone with the mother. Although nurses know that regurgitation, gagging, and brief episodes of cyanosis are normal during this time, these may be very frightening to the mother. Teach the appropriate responses to the behaviors common to this phase. Assess the parent's ability to use the bulb syringe and their comfort with its use. Remind the mother to use the bulb syringe and call for help if needed. Check frequently to see if the infant is having difficulty. Evaluation. The normal newborn has little difficulty clearing the airway after the first few hours of life. The expected outcomes are met if the following occur. The respiratory rate is between 30 and 60 breaths per minute. The infant shows no signs of respiratory distress. Application of the nursing process, thermoregulation. Because any neonate may have difficulty with thermoregulation, the nurse should identify problems and intervene to prevent complications related to this vital function. Assessment. Assess the newborn's temperature shortly after birth, and then according to agency policy. Generally, the temperature is assessed every half hour until it has been stable for 2 hours. It is checked again at 4 hours, and then every 8 to 12 hours, or according to agency policy. Assess the temperature more often if it is abnormal. Identification of patient problems. Ineffective temperature maintenance is a common problem for newborns because of their immature compensation for changes in environmental temperature. Planning, expected outcome. The expected outcome for this problem is that the infant will maintain an axillary temperature within the normal range of 97.7 degrees to 99.5 degrees Fahrenheit, 36.5 to 37.5 Celsius. Interventions. Preventing heat loss. Preparing the environment before birth. Begin preventative measures before the infant is born. Prepare a neutral thermal environment with a radiant warmer to use during initial assessments. This ensures that excess oxygen and glucose are not used to maintain body temperature. Check the radiant warmer to ensure it is functioning properly. Turn it on early enough to warm the bed before the birth. Providing immediate care. Immediately after birth, place the infant on the mother's abdomen to provide warmth from skin-to-skin contact or under a radiant warmer to counteract the cool temperature of the birth environment. Routine assessment and care can be performed while the infant is on the mother's abdomen, and breastfeeding can begin if the mother so desires and both mother and infant are stable. Infants placed skin to skin with the mother immediately after birth are more likely to have stable temperatures. Dry the wet infant quickly with warm towels to prevent heat loss by evaporation. Pay particular attention to drying the hair because the head has a large surface area and hair that remains damp increases heat loss. Remove towels or blankets as soon as they become wet and replace them with dry, warmed linens. Cover the head with a pre-warmed cap when the infant is not under a radiant warmer. Do not use a hat when the infant is under the warmer because it interferes with transfer of heat to the infant's head. When the infant is placed under a radiant warmer, set the servo control, the mechanism that regulates the amount of heat produced, to 36.5 degrees Celsius. This setting regulates the heat from the warmer to maintain the infant's skin temperature at the normal level. Attach the skin probe to the infant's abdomen to allow the warmer to monitor and display the infant's temperature continuously. Check frequently to see if the infant's skin temperature is increasing as expected. Providing ongoing prevention. Warm objects that will come in contact with the infant to avoid conduction of heat away from the infant's body. Pad cool surfaces such as scales or circumcision restraint boards with warm blankets before placing infants on them. Warm stethoscopes and clothing before using them. Before touching the infant, run warm water over your hands if they are cold. To prevent heat loss by radiation in cold weather, position the newborn's crib or incubator away from exterior walls or windows of the building. These sources of heat loss are easily overlooked when the objects and air around the infant seem warm, but infants may lose heat to objects not in close contact with them. Keep this possibility in mind when positioning cribs in mother's rooms, which are often short of space. Place the crib away from windows or doors if possible. Avoid areas with drafts, such as those near hall doors or air conditioners. Keep traffic low around radiant warmers because movement increases air currents, causing heat loss by convection. When assessing or caring for newborns, avoid exposing more of their bodies than necessary. Remove clothing and blankets only from areas being assessed. Keep the upper part of the infant's body covered when changing diapers. Wrap newborns in blankets and place a stockinette or insulated hat on the infant to prevent heat loss from the large surface area of the head. Restoring thermoregulation. If an infant with a previously normal temperature develops a low temperature, institute nursing measures to assist thermoregulation immediately. First, look for obvious causes. The blankets around the infant may have come loose, or the infant's diapers or clothing may have become wet. The mother's room may be too cold, or the crib may have been placed near the air conditioner. These causes can be corrected easily. A slight drop in temperature may only require placing the infant, dressed in just a diaper and hat, next to the mother's bare skin. This skin-to-skin contact is very effective in using the mother's body heat to warm the infant. Place a warm blanket over both mother and infant. If skin-to-skin contact is not possible, add extra clothing. Use 2 blankets, each wrapped separately around the infant, to increase insulation of heat by trapping air between the layers. Place another blanket over the infant in the crib and a hat on the infant's head. Warm linens in a warmer before use if more warmth is desired. A greater drop in the infant's body temperature or a temperature that has not improved within an hour of using skin-to-skin contact requires additional measures. Place the infant under a radiant warmer for a short time. For an infant with a markedly decreased temperature, set the temperature control on the warmer to warm the infant slowly. Gradually increase the temperature until the infant's temperature is within the normal range. Warming the infant too rapidly can cause complications such as apnea. Performing expanded assessments. Expanded assessments are necessary whenever the body temperature decreases in a newborn. Assess the respiratory rate and observe for signs of respiratory distress because non-shivering thermogenesis increases the need for oxygen. Because the cold infant uses more glucose to produce heat, test the blood glucose when the temperature is abnormal, following agency protocol. Ingestion of warm colostrum or breast milk helps warm the infant. Notify the physician or nurse practitioner if the infant does not respond to these measures. Place the infant under a radiant warmer or in an incubator for close observation until the temperature stabilizes. Evaluation. When the infant's body temperature has been maintained within the normal range for several hours, the infant can be considered stable. Continue to monitor thermoregulation throughout the stay. Application of the nursing process. Hepatic function. The major early assessments and care of the hepatic system are related to blood glucose and bilirubin conjugation. Blood glucose. Assessment. Assess all infants for risk factors and signs of hypoglycemia. Perform screening tests for blood glucose according to the symptoms and agency policy. Identification of patient problems. The infant is considered hypoglycemic when the glucose level is below 40 to 45 milligrams per deciliter. These infants have the potential for injury because of decreased blood sugar levels. Planning. Expected outcomes. Hypoglycemia requires an interprofessional approach between the nurse and the provider. The nursing plan of care will reflect both dependent and independent nursing functions. Agency protocol usually allow the nurse to intervene for hypoglycemia and then notify the provider of the infant's response. Planning revolves around the nurse's role, including the following. 1. Assessing for signs of hypoglycemia. 2. Notifying the provider of signs of hypoglycemia or following hospital protocol for infants with hypoglycemia and then notifying the provider. 3. Intervening to minimize hypoglycemia. Interventions. Maintaining safe glucose levels. Follow agency policy and physician orders regarding feeding infants with low glucose levels. A common practice is to feed the newborn if the glucose screening shows 40 to 45 milligrams per deciliter or less to prevent further depletion of glucose. Infants with severe hypoglycemia may need intravenous feedings to provide glucose rapidly. For most infants, breastfeeding or giving formula is sufficient. Glucose water alone is not recommended for newborns because the rapid rise in glucose results in increased insulin production, causing a further drop in blood glucose. Milk provides a longer-lasting supply of glucose. Assist the breastfeeding mother with the feeding. Help formula feeding mothers with positioning the infant and the bottle. Explain the need for prompt feeding in infants with hypoglycemia. Repeating glucose tests. Until blood glucose is stable, closely observe newborns who have shown signs of hypoglycemia. Repeat glucose screenings may be performed according to agency policy. Keep the physician or nurse practitioner aware of the newborn's status. If the blood glucose does not remain at an adequate level, other causative factors are investigated. The infant may be transferred to an intensive care nursery for more treatment, including intravenous feedings, until the blood glucose is stabilized. Providing other care. Watch for signs of other complications. Infants who do not have enough glucose may experience a drop in temperature that could lead to respiratory distress as oxygen is used for non-shivering thermogenesis. The parents will be distressed over the multiple heel sticks their infant must endure. Explain the importance of maintaining adequate blood glucose and why the tests and frequent feedings are necessary. Discuss the plans for blood testing and criteria for discontinuing it. Evaluation. In evaluating collaborative interventions for hypoglycemia, note the infant's response to interventions and the presence or absence of continued signs of hypoglycemia. The blood glucose should remain above 40 to 45 milligrams per deciliter. Bilirubin. Because elevated bilirubin is common in newborns, be alert to situations that require intervention. Assessment. Assess for jaundice by blanching the infant's skin on the nose or sternum. Assess for jaundice every 8 to 12 hours along with vital signs. Determine how far down the body the jaundice extends. Because visual assessment of jaundice is unreliable to determine the degree of hyperbilirubinemia accurately, obtain transcutaneous or serum bilirubin measurements in any jaundiced infant. Compare the results with what is expected for the infant's age and previous results. Identification of patient problems. Hyperbilirubinemia may not occur until after discharge, especially if discharge was early. The newborn has a potential for jaundice because of the parent's lack of knowledge about hyperbilirubinemia. Planning expected outcomes. The expected outcomes for this problem are as follows. 1. Parents will identify methods for preventing or reducing jaundice. 2. Parents will seek treatment if jaundice develops or worsens after discharge. Interventions. Determine which infants are at increased risk for hyperbilirubinemia. Explain the significance of jaundice to parents and show them how to assess for color changes in the skin. Answer parents' questions about blood tests, phototherapy, and other care. Discuss the importance of adequate feedings to stimulate passage of stools and prevent high levels of bilirubin. If a newborn is feeding poorly, determine the reasons and intervene appropriately. Help mothers wake sleeping infants to feed. Encourage them to spend extra time with the infant with a poor suck, and explain the appropriate amount to give at each feeding. Explain that giving water to jaundiced infants does not stimulate stool excretion and should be avoided. If the infant is breastfeeding, evaluate the infant's suck and the mother's understanding of positioning and other techniques. Instruct mothers to nurse at least 8 to 12 times each 24 hours for adequate lengths of time. Assist mothers having difficulty to ensure infants are feeding well before discharge. Refer to a lactation consultant if needed. Instruct parents to contact their care provider if they see an increase in jaundice if the infant is not eating well, not voiding at least 6 times daily by the 6th day, or not producing stools appropriately, at least 1 stool per day for formula-fed infants, and at least 4 stools daily for breastfeeding infants. Stress the importance of making and keeping follow-up appointments with the infant's healthcare provider. Offer written materials about jaundice for the parents to take home. Continue to check the infant for jaundice during early clinic or home visits. Transcutaneous or serum bilirubin levels may be used to determine the degree of jaundice. Reinforce teaching about identification of jaundice and importance of feedings and stooling. Answer questions that have occurred to parents since discharge from the birth facility. If an infant develops true breast milk jaundice, explain it to the parents. The mother who must discontinue breastfeeding for 1 or 2 days will be very concerned. Reassure her that her milk is adequate and not harmful to the infant. Help her maintain her milk supply by using a breast pump during the time the infant is taking formula. Evaluation. With proper nursing observation and parent teaching, infants with hyperbilirubinemia are identified early to allow for appropriate treatment and prevention of injury. Parents are able to discuss signs, prevention, and management of jaundice at home. Ongoing assessments and care. A complete assessment is necessary every 8 hours or according to birth facility policy, but the nurse should always watch for signs of change in the newborn's condition. Vital signs are assessed more often if they are abnormal. The infant is weighed once daily and weight loss or gain is documented. Providing skin care. The skin should be assessed for new marks or changes in old ones. To assess skin turgor, the nurse pinches a small area of skin over the chest or abdomen and notes how quickly it returns to its normal position. The return should be immediate in the normal newborn with no tenting. Skin that remains tented is an indication of dehydration. Bathing. The newborn receives a bath to remove blood and amniotic fluid as soon after birth as the temperature is stable. A temperature of 36.7 Celsius (98 Fahrenheit) or higher is often used to determine when to bathe the infant. Removal of all vernix is unnecessary. Early bathing decreases exposure to maternal blood and possible blood-borne organisms of the infant's skin. The bath is given before any invasive procedures, such as injections or heel sticks, that might draw organisms on the skin into the infant's tissue or bloodstream. If the skin must be punctured before the bath is given, the area is washed well first. The infant may be bathed by immersion in a tub. Studies have shown that tub bathing does not increase infection or decrease cord healing. Infants maintain their temperatures better during tub bathing than during sponge bathing. To be kept warm, infants should be immersed in water that covers their shoulders. Water temperature should be approximately 38 degrees to 40 degrees Celsius, 100 Fahrenheit to less than 104. If a sponge bath is given, it can be done with the infant under the radiant warmer to help maintain the infant's temperature. The bath should be performed quickly and the infant thoroughly dried to prevent heat loss by evaporation. While shampooing the hair, the nurse combs through it to remove dried blood. Combing the infant's hair hastens drying. The infant remains under the radiant warmer until the hair is dry and the temperature returns to the previous level. The infant is dressed and wrapped in 2 warm blankets, and a warm cap is placed on the infant's head before he or she is removed from the radiant warmer. The temperature should be rechecked within 1 hour to ensure that the infant is maintaining thermoregulation adequately. Bathing the infant in the presence of the parents allows the nurse to point out infant characteristics in addition to demonstrating the bath procedure. It is also a good time to teach parents about safety precautions. After the initial bath, the infant may not receive another full bath during the stay in the birth facility. The skin is cleansed at diaper changes and to remove regurgitated milk. Clear water or a mild soap solution is used, according to agency policy. Providing cord care. The cord should be checked for bleeding or oozing during the early hours after birth. The cord clamp should be securely fastened with no skin caught in it. Purulent drainage, or redness, or edema at the base indicates infection. The cord begins to dry shortly after birth. It becomes brownish black within 2 to 3 days and falls off within approximately 10 to 14 days. Evidence-based practice guidelines show that cleaning the cord with water when necessary and keeping it clean and dry is the best method of cord care. This natural treatment of cords may shorten the time of cord separation and does not lead to increased infections. The diaper is folded below the cord to keep the cord dry and free from contamination by urine. The cord clamp is removed about 24 hours after birth if the end of the cord is dry. Although the base of the cord is still moist, there is no danger of bleeding if the end is dry and crisp. Cleansing the diaper area. Because contact with body fluids is likely, it is important to wear clean gloves while changing diapers. Meconium is very thick and sticky and can be difficult to remove from the skin. Plain water or mild soap solutions may be used for cleaning the diaper area. If commercial diaper wipes are used, they should be free of detergent and alcohol. Assisting with feedings. The nurse should ensure the infant is eating well and that parents understand their chosen feeding method. This is particularly important for breastfeeding infants. A short period of observation at the start of feedings, followed by another check during the feedings, will help the nurse identify any problems that may have developed. Positioning for sleep. Parents need to understand how to position infants properly. Placing infants in the prone position for sleep is associated with an increased risk for sudden infant death syndrome, SIDS. The AAP Task Force on SIDS recommends that mothers be taught to place infants on their back for sleep because this position is associated with the lowest rate of SIDS. It is important for nurses to model correct positioning for sleep for parents by positioning the newborn on his or her back to sleep at the birth facility. Parents should also be taught to use a firm sleep surface without bumper pads and avoid loose or soft bedding that might interfere with breathing. Sack-like sleepers that take the place of blankets are available. The infant should not sleep in a bed or on a couch with another person. However, placing the infant's bed in the parent's room is recommended. Giving a pacifier when putting the infant to sleep is also recommended, but this may be delayed for 1 month in infants who are breastfeeding to help establish breastfeeding. Overheating during sleep should be avoided. Positioning and head shape. Infants who spend long periods in the supine position may develop flattening or asymmetry of the back of the head, positional plagiocephaly. This occurs because the bones are not fully developed and can be molded by positioning. To prevent flattening of the head, infants should be placed on the abdomen several times each day while they are awake. This tummy time is an opportunity for play and interaction with the parents. It is essential that infants be supervised at all times when in the prone position, and they should be moved to the supine position if they fall asleep. Protecting the infant. Safeguarding the infant is a major nursing role. Primary ways nurses protect newborns are by 1. Ensuring that infants always go to their correct parents. 2. Taking precautions to prevent infant abductions. 3. Preventing infections or recognizing early signs. And 4. Preventing infant falls. Identifying the infant. Methods to identify the infant, mother, and a support person are used to ensure that an infant is never given to the wrong person. Electronic devices or identification bands with imprinted numbers are used. The electronic device is designed to set off an alarm if removed or the infant is taken beyond a certain area of the facility. The devices or bands are used to identify the mother and the infant at any time the infant is brought to the mother after a period of separation, however brief. All staff should follow the facility protocol for identification of infants. Other methods to identify infants include taking footprints of the infant and a fingerprint of the mother or photographs of the infant. Birthmarks or other distinguishing features are carefully documented in the nurse's notes. Preventing infant abduction. An essential nursing role is protecting the infant from abduction, kidnapping. Between 1983 and 2014, 132 infants were abducted from healthcare facilities. 119 were abducted from homes, and 41 were abducted from other places. Many of the abductions from healthcare facilities, 58%, were from the mother's room. Infants have been safely returned to their parents in 96% of hospital abductions. Newborns are usually abducted by women who are familiar with the birth facility and its routines. They usually visit more than one agency several times to learn the routines so they can impersonate birth facility staff to gain access to a newborn. They often know the layout of the facility and the locations of exits well. The profile of the abductor is a woman of childbearing age, often overweight, who may want an infant to solidify her relationship with her husband or boyfriend. She may be pretending to be pregnant, have had a previous pregnancy loss, or be unable to have a child of her own. Although the woman plans the kidnapping, she waits for an appropriate opportunity to take any infant available. She may wear a uniform to impersonate hospital staff and tell the parents she is taking the baby to have a test performed. Many precautions are necessary to protect infants from abduction. Additional information about abduction is available for parents and professionals at the National Center for Missing and Exploited Children website, www.missingkids.com. Preventing infection. Because the newborn has a limited ability to combat infection, prevention is of utmost importance and constitutes a major part of parent teaching. Many nursing actions help prevent infection. At the beginning of their shift, nurses wash their hands and arms thoroughly. Throughout the day, hand hygiene, according to agency policy, is important before and after touching any infant. To avoid cross-contamination, each infant's supplies are kept separate from those used for other infants. Supplies in drawers or cupboards of each crib unit should be used only for that infant. The nurse should instruct parents and visitors to wash their hands before touching infants. Parents should be instructed to discourage visitors with colds or other infections from visiting the mother and the newborn at the birth facility or during the early weeks at home. Nurses should be vigilant for signs of infection during assessment and care of the infant. These signs are often different from those in the older infant or child and may be subtle. Instead of a fever, the infant's temperature may decrease. The infant may feed poorly, be lethargic, or have periods of apnea without obvious cause. Any change in behavior that is unexplained should be recorded and investigated. The same holds true, of course, for the more obvious signs of infection, such as drainage from the eyes, cord, or a circumcision site. Preventing infant falls. Infant falls are another concern. They are most likely to happen when mothers are feeding infants during the night. Because the mothers are often exhausted, they may fall asleep, loosening their hold on the infant, who then slips from the bed. Nurses should offer to help mothers who are very tired and encourage them to put infants into their cribs when they become sleepy. Checking frequently on mothers who are feeding during the night can reinforce this. Circumcision. In the United States, circumcision is the most common surgical procedure performed on males. It is the removal of the prepuce, foreskin, a fold of skin that covers the glans penis. Although it can be retracted easily for cleaning in the older child, the prepuce may not be fully retractable until 3 to 6 years of age. The prepuce should never be forcibly retracted in any infant because trauma and adhesions can result. Circumcision is a controversial issue, and parents may have questions about choosing it for their son. The AAP recently stated that the health benefits of circumcision outweigh the risks of the procedure, and that the benefits are not so great that it should be recommended as a routine for all newborns. Parents should have access to circumcision if they choose it for their infants. Reasons for choosing circumcision. The major benefits of circumcision are that it reduces penile cancer, urinary tract infections in the first year of life, HIV infection, and transmission of other sexually transmitted diseases. Some parents choose circumcisions for religious, cultural, or social reasons. Some parents want their son to look like his circumcised father or peers. Others think circumcision is an expected part of newborn care, and some do not realize they have a choice in the matter. Lack of knowledge about care of the prepuce leads to some circumcisions. Poor hygiene may increase the risk for infections and other problems. Teaching parents and children about proper care of the uncircumcised penis can prevent complications related to inadequate cleanliness. Reasons for rejecting circumcision. Parents decide against circumcision for various reasons. Some parents believe that the incidence of conditions more common in uncircumcised males is too low to warrant the pain and risks associated with surgery. Others believe that having the infant circumcised to look like the father or peers is cosmetic surgery and therefore unnecessary. These parents especially object to subjecting their son to pain during and after surgery. Circumcision is less often practiced by families from Asian, Hispanic, and Native American cultures. It is less common in Europe, Asia, South and Central America, Canada, and Australia. Parents may be concerned about removing the prepuce, which serves to protect the glans. The glans is more prone to irritation from constant exposure to urine and rubbing against diapers when unprotected by the prepuce. Complications of circumcision are rare but include hemorrhage and infection, removal of too much or too little of the prepuce, an unsatisfactory cosmetic result, urinary retention, stenosis or fistulas of the urethra, adhesions, necrosis, or other injury to the glans penis also may occur. Only healthy newborns should undergo circumcision. The preterm or sick infant should not be circumcised until he is healthy enough to tolerate the procedure. For the repair of anatomic abnormalities of the penis, such as hypospadias or epispadias, an intact prepuce may be needed for use in plastic surgery. Pain relief. The AAP recommends that adequate pharmacologic pain relief be given to newborns during circumcision. A dorsal penile nerve block, anesthetic injected into the dorsal penile nerve, is a safe method to eliminate pain during circumcision. It has been found to be more effective than other methods of pain relief. EMLA, eutectic Mixture of local anesthetics cream may be applied to anesthetize the skin before the procedure, but it is less effective than anesthetic injection and requires a longer waiting period before it is effective. Acetaminophen may be given throughout the first day for post-procedure pain. Non-pharmacologic pain relief methods include pacifiers, oral sucrose, soothing music, recordings of intrauterine sounds, decreased lights, and talking softly to the infant. All have shown some success in reducing an infant's pain responses to circumcision, but are not as effective as anesthetics. Pain and pain management in newborns is discussed further in Chapter 23. Methods. The Gomco Yellen clamp and Plastibell are two devices used for performing circumcisions. In both methods, the prepuce is first separated from the glans with a probe and incised to expose the glands. A Mogen clamp may also be used for circumcisions, especially for ritual circumcisions of Jewish infants. Nursing considerations. Assisting in decision making. Ideally, parents decide about circumcision early in pregnancy on the basis of a careful consideration of risks and benefits. Although the physician is responsible for explaining the risks and benefits of circumcision to parents, the nurse may be used to answer questions or clarify misconceptions. Although nurses generally teach parents of circumcised infants how to care for the penis, they may not think about providing teaching for parents who decide against circumcision. Proper care of the intact penis should be included in the teaching plan for these parents and should be discussed with parents who are undecided about the procedure as well. Providing care during circumcision. As with any surgical procedure, informed consent from parents is necessary before a circumcision is performed. The nurse sees that the consent has been signed, the infant is stable, and vitamin K has been given to prevent excessive bleeding. The physician is informed of any problems that might impair the infant's ability to withstand circumcision. The nurse gathers equipment and supplies before the procedure. To prevent regurgitation and possible aspiration while the infant is restrained in the supine position, feedings may be withheld for 2 to 4 hours before the procedure. A bulb syringe should be placed nearby in case suction is necessary. When the physician and equipment are ready, the infant is placed on a circumcision board. A warm blanket is placed under the infant, and a surgical drape provides warmth and maintains sterility. A heat lamp or radiant warmer helps prevent cold stress. The nurse should comfort the infant during the procedure. The physician administers the anesthesia. The nurse may provide a pacifier or sucrose, talk to the infant, or play soft music or recordings of intrauterine sounds to help distract the infant from pain. Evaluating pain. Nurses should evaluate the infant's pain with one of the pain scales available for use with newborns. An example is the Neonatal Inventory Pain Scale, NIPS. The scale measures facial expression, crying, breathing pattern, muscle tone of the extremities, and state of arousal. The infant's pain responses should be measured before, during, and after the procedure. Providing post-procedure care. The infant should be removed from the restraints immediately after the circumcision is completed. If a Gomco clamp was used, the nurse squeezes petroleum jelly on the circumcision site to prevent the diaper from sticking to it. A small piece of gauze may be placed over the area. Petroleum jelly should not be used with a plastibell because it may cause the ring to be displaced. The diaper is attached loosely to prevent pressure. The infant should be comforted and returned to his mother, who may be anxious about her son. Breastfeeding will provide comfort to both the baby and his mother. The nurse watches carefully for signs of complications after the circumcision. The wound is checked frequently for bleeding during the first few hours after the procedure. If the infant is to be discharged after the circumcision, he should be observed for at least 2 hours before release. If excessive bleeding occurs, pressure is applied to the site. The nurse notifies the physician, who may apply gel foam or epinephrine, or may suture the small blood vessels. Even a small amount of blood loss may be significant in an infant who has a small total blood volume. Noting the first urination after circumcision is important because edema could cause obstruction. If the infant goes home before voiding, the mother is instructed to call a physician if the baby does not urinate within 6 to 8 hours. Teaching parents. Because circumcision is often performed on the day of discharge, the parents take over care of the site. Each time the site is checked for bleeding, the nurse should show the parents the amount of blood on the diaper and help them understand how much to expect. The normal yellowish exudate that forms over the site should be described and differentiated from purulent drainage. Signs of complications should be discussed thoroughly with parents. Application of the nursing process. Parents' knowledge of newborn care. Parents often feel anxious about taking over total care of their newborn. Mothers dealing with exhaustion and physiologic changes from childbirth may have difficulty remembering the extensive information they are given. Therefore, finding creative teaching methods is especially important. The nurse should use every contact with the parents as an opportunity for further teaching. Assessment. Assess parents' changing learning needs throughout the birth facility stay. Consider the mother's and infant's physical conditions and any special concerns the mother may have. Determine the learning needs of experienced mothers. They may be unaware of information that has changed since the birth of the last infant. Concerns about helping other children adjust to the newborn may be especially important. Assess the father's learning needs and his plans for involvement in infant care. Determine whether there are cultural dictates about the father's participation in infant care. They often have many questions and are eager to learn about care of their infant. Identification of patient problems. In general, newborns are healthy. Nursing care is wellness-oriented. Patient problems center around parent education. Most parents are ready to improve their knowledge of infant care in anticipation of discharge. Planning expected outcomes. The primary expected outcomes for this teaching opportunity are that before discharge, the parents will do the following. 1. Identify their own information needs and seek assistance from nurses to meet those needs. 2. Correctly demonstrate infant care. 3. Express confidence in their ability to meet their infant's needs. Interventions. Setting priorities. Because of the short time available for teaching, set priorities in determining what to teach. After assessing the parents' learning needs, make a teaching plan with them. Use a topic list to help them point out major concerns regarding infant care to ensure effective use of the teaching time. Begin by discussing their most pressing concerns to decrease anxiety so they can concentrate on the information. Then proceed to other subjects. Use various teaching methods. Use a variety of teaching methods to increase effectiveness, make the subject more interesting, and increase retention of the material. Use verbal and written methods, demonstrations, and return demonstrations. Parents often learn best by seeing skills performed correctly and then practicing them while the nurse gives suggestions. To increase the likelihood that parents will follow instructions, explain the rationale for each point made during teaching sessions. Use audiovisual materials, including pamphlets, magazines, television programs, and internet sites. Highlight the most important areas in written material. Discuss the programs with the new mother and clarify information as necessary to reinforce learning. Many parents use the internet to obtain information about childcare. Suggest that they look for websites provided by well-known organizations such as the American Academy of Pediatrics. Warn them to be wary of sites with unclear sources of information that seem contrary to generally accepted knowledge. Suggest they have their healthcare provider confirm the validity of the information if they are unsure about it. Commend parents for their interest in obtaining information to increase their parenting skills. Texts to cell phones are another source of information. One source that provides tips for infant care during the first year is Text for Baby from the National Healthy Mothers, Healthy Babies Coalition. Modeling behavior. Mothers watch closely when nurses handle infants. Nurses model mothering behavior by the way they hold, care for, and talk to infants. Modeling is particularly important for the mother with no experience in infant care. Use every opportunity during general care of the infant to point out infant characteristics and behavior states and to model how to calm crying infants. Teach mothers to use progressive consoling interventions such as talking to the infant, folding the infant's arms across the chest, holding, swaddling, and facilitating sucking of the infant's finger or a pacifier. Point out the different behavior states and how to help infants move to a more awake state for feeding. Instruct parents to intervene before infants reach the point of frantic crying. Teaching intermittently. Plan teaching in small segments that are interspersed with infant care. Check the parents' understanding often. Encourage them to take over various tasks until they are performing all of the infant's routine care. Use a checklist of major teaching topics to ensure that all important areas are covered. Include the partner. Identify partners who would like to participate in the care of their infants but hesitate because they lack experience. Offer them the same teaching given to the inexperienced mother. Give praise liberally to increase confidence when the partners practice their new infant care skills. Documenting teaching. Document all teaching performed and the evaluation of the parent's abilities to carry out infant care. This information shows other nurses what teaching has been completed and what is still needed. It also provides legal proof that teaching was completed before discharge. Providing for follow-up care. If the mother and infant will be seen by a clinic or home visit nurse, provide information about unmet learning needs. Reinforcement then can be provided at a time when the mother's memory has improved after the stress of birth. Give as much information as possible in written form so that parents can refer to it later if they have concerns. Also, provide telephone numbers that they can call for further help. Offer written information in the parent's primary language, if possible, even if they speak English as a second language. They may prefer to read the information in their native language. Remind parents about timing of follow-up care. Suggest that they schedule the appointment before they leave the birth facility. Incorporating cultural considerations. Consider the family's cultural beliefs about childcare when teaching. Asian parents may be uneasy when caregivers are too complimentary about the baby or casually touch the infant's head. Mexican parents, however, may prefer that a person who compliments the infant touch the infant to ward off the mal ojo or evil eye. Some cultures may delay naming of the baby or choose ugly names to decrease the envy of evil spirits. Care of the cord differs in various cultures too. Women from Mexico may strap a coin to the navel to keep it attractive. Other women may use a binder or belly band to put a raisin or oil on the cord. Ask the parents who will be helping them care for the baby to determine family members who should be included in the teaching. This varies according to the culture and availability of the traditional caregiver. In addition to the father of the infant, the woman's mother is often the major support person. However, in the Korean culture, the husband's mother is the primary caregiver for both the infant and the mother in the early weeks. Elicit questions during the discussions. However, be aware that women from some cultures will not ask questions. For many Native Americans, asking questions is considered rude. Other women may be too shy or uneasy about their limited English. When questions are not asked, discuss questions often asked by other parents. Evaluation. Ongoing evaluation of parents' learning is necessary throughout the birth facility stay and during the follow-up home, clinic, or office visits. Determine whether the parents think their questions have been answered or if they can demonstrate important aspects of infant care safely and correctly. As they learn more caregiving skills, they should verbalize more confidence in their abilities. Immunization. Immunization for hepatitis B is now included with other routine childhood vaccinations. Newborns of mothers with acute or chronic hepatitis B infection, hepatitis B surface antigen, HBsAg positive, may become infected from exposure to the mother's blood at birth. Infected infants have a very high chance of developing chronic infection, which may later cause cancer or other serious liver disease. These infants should receive both the vaccine and hepatitis B immune globulin, HBIG. HBIG provides passive immunity against hepatitis to protect infants until they develop their own antibodies and should be given within 12 hours of birth. The vaccine promotes antibody formation to protect infants from further exposure to the disease. The rest of the vaccine series is given in the healthcare provider's office or in a clinic. Newborns or uninfected mothers also receive hepatitis B vaccine. It is often given during the stay in the birth facility, but may also be given later in the pediatrician's office. A national voluntary standard for perinatal care is that all infants receive the appropriate hepatitis prophylaxis before discharge. Parents should be referred to their pediatrician for 2 more doses of the vaccine after discharge. Newborn screening tests. Prompt identification and treatment of infants with conditions that can affect their survival or long-term health is essential. Newborns may be screened for critical congenital heart defects, hearing, metabolic, hematologic, and genetic disorders. Each state determines which specific tests are performed before discharge from the birth facility. Infants identified by these tests may need repeat screening or more complex diagnostic testing.